Hi, I'm Jenny Shao, the outgoing fellow at Carolinas Medical Center. I'll be joining the faculty at the University of Pennsylvania in the coming months. I'm presenting our research regarding best reoperative strategies for failed fundoplication. These are our disclosures. Gastroesophageal reflux disease is highly prevalent in the Western world and can affect as many as 40% of the Western population. With increase in incidence of reflux, there's been a higher incidence of laparoscopic anti-reflux operations performed, and since its introduction in the 90s, has been widely considered the gold standard for surgical management of GERD. While many people do well, there's a small subset of patients who fail, and an even smaller number still that require additional revisional surgery due to persistent symptoms. There have been numerous studies that examine why fundoplications fail. The most commonly cited failures include obesity, foreshortened esophagus, recurrent hiatal hernia, or herniation of the fundoplication into the chest, disruption of the fundoplication, slip fundoplication, and failure to excise the hernia sac. The two most commonly cited anatomic reasons for failure are intrathoracic wrap migration and a loose or slipped wrap. Although there are many technical reasons for early failure after laparoscopic anti-reflux operations, there are patients who are at increased risk for failure. These patients commonly demonstrate a persistent high transdiaphragmatic pressure gradient and may have chronic conditions associated with cough or retching. Other patients may have an anatomically foreshortened esophagus that predisposes to intrathoracic wrap migration. Patients with obesity also have been shown to have increased rates of failure for multifactorial reasons, including an increase in the transdiaphragmatic pressure gradient from increased abdominal girth. Currently, no randomized controlled trial exists to examine the best course of action for patients requiring reoperative surgery after failed fundoplication. In one of the largest case series at a single institution, this review seeks to compare long-term outcomes of revisional Roux gastric diversion compared to redo fundoplication. The aim of our study was to examine patients with previous failed fundoplications and symptomatic recurrence and to assess whether or not conversion to Roux gastric diversion or redo fundoplication resulted in better resolution of reflux symptoms. Our secondary aims were to assess resolution of other preoperative symptoms, comorbidities, and procedure complications. We identified 180 patients who had a prior history of fundoplication with recurrent symptoms and were interested in undergoing reoperation. 56% of patients underwent a Roux gastric diversion, and the remaining 43.9% underwent redo fundoplication. All patients underwent comprehensive history and physical and preoperative workup based on the presenting symptoms to evaluate for potential reasons for failure on their initial operation and to assess any potential abnormalities that will need to be redressed on reoperation. Most commonly, the workup included endoscopy, upper GI, manometry, pH testing, and gastric emptying studies. The workup was tailored for each individual specific patient. Operatively, all patients underwent initial deconstruction of their previous fundoplication, full hiatal mobilization to obtain 2 to 3 centimeters of intra-abdominal length. Small number of patients required a callus gastroplasty in order to achieve that length. All patients also underwent hiatal closure with permanent sutures, with 50% of patients requiring bioabsorbable mesh placement at the hiatus. For patients undergoing Roux gastric diversion, depending on the initial patient BMI, they either had a 30 or 50 milliliter gastric pouch reconstructed, and a Roux limb anywhere between 60 centimeters to 150 centimeters was created. A fundectomy was also commonly performed if there was evidence of ischemia in the gastric remnant. In patients undergoing redo fundoplication, most commonly a toupee or nissen was constructed depending on the patient's specific preoperative evaluation and symptoms. Our patient characteristics show that patients who underwent diversion were more commonly female, had a higher average BMI of 34 compared to 27, and had higher rates of obstructive sleep apnea. The two groups were not different in all other comorbidities. On preoperative evaluation, we also found that the diversion group had higher rates of regurgitation and vomiting. They also had longer asymptomatic intervals prior to reoperation and tended to have higher rates of abnormal motility. Both groups had high rates of preoperative heartburn and dysphagia. They also had similar rates of wrap herniation or evidence of slip fundoplication on preoperative evaluation. Operatively, the Roux gastric diversion group had a higher number of previous failures, with 31% of patients having 2 or more failed prior fundoplications, while the redo group only had 6%. Operative time and estimated blood loss was also significantly higher in the diversion group. Both groups were similar in terms of conversion to open, concomitant hiatal hernia repair, and percentage of repairs requiring mesh. On postoperative follow-up, we find that there's no significant difference in recurrence of reflux symptoms between the two groups. The diversion group, however, did have much higher rates of obesity resolution with a mean decrease of 6.8 BMI points compared to 0.7 in the fundoplication group. We also found high rates of comorbidity resolution in the diversion group, with almost 36% of patients achieving a BMI of less than 25 on follow-up. We see that in both pre-Roux-en-Y gastric diversion groups and pre-redo fundoplication groups had much higher rates of heartburn, abdominal pain, dysphagia, and vomiting than their post-intervention groups for Roux-en-Y gastric diversion in all categories and redo fundoplication in all categories. In both Roux-en-Y gastric diversion and redo fundoplication groups, patients had a similar percentage decrease in their preoperative symptoms. Overall, the Roux-en-Y gastric diversion group had a longer length of stay compared to the redo fundoplication group, and the 30-day readmission rate was slightly higher, but was not significant. The reoperation rate was higher in the diversion group, but most of the reoperations occurred at a mean of 1.5 years after the initial operation and were due to internal hernias, bowel obstructions, and incisional hernias. Only 3 patients required immediate operation as a result of a anastomotic or staple line leak. We find that overall, between the two procedures, reoperative surgery for failed fundoplication has an 85.5% success rate for resolution of reflux symptoms. Both operations are technically feasible, safe, and effective options in appropriately selected patients. The study is limited as it is a single institution study and includes patient-specific, tailored approaches in surgery selection. Future randomized controlled trials will be needed to determine patient-specific guidelines for diversion versus redo fundoplication. Based on our experience, we propose several considerations. In patients with a BMI of greater than 35, especially if they have obesity-related complications and abnormal motility, should be considered for diversion. Patients with a BMI of 30 to 35, a patient symptom tailored approach is used, and patients who've had 2 or more failed fundoplications or have evidence of visceral obesity should be considered for diversion. In patients with a BMI of less than 30, normal motility and anatomic reasons for their symptoms can be offered a redo fundoplication. Thank you so much to SAGES for allowing me to present my work, and to my incredible research team and mentors at Carolinas Medical Center. All of this would not be possible without you. Thank you.